Well, thanks for that introduction, and thank you for including this session on pediatrics in today's seminar. It's a fantastic year that we've just had, a historic year starting to treat children, cure them from hepatitis C with evidence-based pediatric studies to support what we're doing. Almost unique experience in pediatric hepatology, I would say. I have a couple of great colleagues from pediatrics here in the room with me. I know that probably most of you are not directly involved with pediatric hepatitis C, so I will take you through this talk to raise some of the important points as I see them. These are my disclosures. I'm a site PI for a couple of industry-sponsored studies of viral hepatitis in children. So the objectives are really to understand the spectrum of disease that we see in children infected with hepatitis C, to discuss the indications and goals for treatment, and to think about some of the barriers to universal access for infected children. So let's start with the prevalence of hepatitis C in children. I know that many of you will think of this as a very small area of concern in comparison to the number of infected adults. The perspective that you take on that, I think, depends on who you are and how you're looking at it. It is true that these are the numbers that are quoted, about 3.5 million children in the world infected with hepatitis C, 0.3% high-income countries, 0.6% in low-income countries. And this chart arises from a systematic review which hasn't been published but is quoted in the review article that I've cited there in Lancet Gastroenterology Hepatology last year. And I would really encourage you, if you're interested in learning more about this area, to read that review. The countries in the chart represent about 80% of the world's pediatric hepatitis C. A lot of these studies are old and limited by the usual problems with trying to understand how many people have hepatitis C in the world, in that lots of them haven't been tested and don't know. So how do children get hepatitis C? The vast majority now is vertically acquired from their mothers. And in most of the published series and the clinical trials, you'll see that proportion ranging from about 75 to 95%. Others get it some other way, and we have a real dearth of data to understand how likely it is to acquire hepatitis C through other mechanisms during childhood. We know of cases where it has happened through iatrogenic means, unsafe healthcare practices, usually in low-income countries, families who have either immigrated to us here in Canada or who go home to visit family. But we don't know details of that incidence. We suspect and know occasionally that injection drug use amongst teens is the route by which hepatitis C is acquired. Most studies of this sort of thing do not go below 18 years of age, however, so the data there is really lacking. And similarly, we know that young men are beginning to have sex with men during their teenage years, and we don't understand the risks and the likelihood of transmission in detail there. The consequences of infection we know a little bit more about. First of all, for those acquiring the infection vertically, we know that a proportion will clear the virus during the first several years of life. People usually talk about the first 3 or 4 years of life. Our co-chair, Dr. Roberts, working with Latifa Jung, reviewed this area and found that that can stretch out to as much as 7 years of life for spontaneous clearance of vertical acquisition. And we know that amongst all the published case series of children with hepatitis C, typically about 1 or 2% of the children have cirrhosis. But these are populations of various ages throughout childhood. The actual development of cirrhosis by 18 years of age, we don't have good figures for that, but it's going to be less than 5%. Similarly, we don't know how likely it is to decompensate, but we know that's a rare event. and we know that there are case reports of hepatocellular carcinoma in children with hepatitis C, and we also know that that's very rare. In our clinical experience, we see that those who get into trouble with severe liver disease will frequently have significant comorbidities that we presume are responsible for the disease progression. Obesity, cancer and its therapies, diseases requiring recurrent blood transfusions leading to secondary iron overload, etc. So when we look at the spectrum of severity of liver disease among children with hepatitis C, we can turn to studies of liver biopsies, such as this from Hepatology 2008, in which we can see that most of the disease is indeed mild. So the blue pie chart there shows the severity of fibrosis, and 2% have cirrhosis in the dark blue. Interestingly, perhaps only 14% have no fibrosis, and the majority of children have some degree of mild or moderate fibrosis going on. Similarly, for inflammation, very few have marked inflammation. A larger number have minimal or no inflammation, and about half will have some moderate degree of inflammation on their liver biopsies. So mostly this is a mild disease. But what about the other consequences of infection for children? There are case reports of extrahepatic manifestations. I know that is a much bigger issue to deal with in adult hepatology and hepatitis C, but although reported in children, these are rare. What we worry about is the stigmatization, and this is what we hear of in clinics when we're seeing teens and when we're talking to them or to their parents, that they worry about what others think of them with their infection. They tend to feel they have to keep it secret. They worry about that secret being found out. They worry about passing on the infection, the consequences of that. And this is an area we have really very little, if any, data on. And I think at the moment, no good validated tools to measure that among teens and caregivers. We do have data on quality of life, and that shows clearly that there's impairment of quality of life, and interestingly, particularly among the caregivers. So stress amongst families, strain on family relations clearly stands out from those studies, as well as some behavioral problems among the affected children. Fortunately, we also have data now that shows that quality of life improves with treatment for both the infected children and their caregivers. Here's one example of a study from a couple of years ago from one of the treatment trials, in which the quality of life measured before treatment at time 0 on that graph among the caregivers in the solid lines and the adolescents themselves in the dashed lines, you can see is decreased pre-treatment and improves subsequently after that. So what about these clinical trials of treatment? We now have a number of published studies looking at children of different ages with different genotypes and different products. I'll just go through these quickly. So first of all, the data on sofosbuvir ladipasvir started in the adolescent study, 12 to 17 years, and then you can see subsequently a 6 to 11-year-old study, and then a 3 to 6-year-old study, primarily, of course, genotype 1, and showing these very high success rates for SVR12. Then we have 2 studies looking at sofosbuvir ribavirin, again the adolescent study first, and then younger children 3 to 12 years old for genotypes 2 and 3. Similarly, very high success rates, 98%. As you go down to these younger age groups, there is weight-based dosing. It was fairly simply worked out in the end to these 3 categories of weight of child, so 17 kilo and 35 kilo cutoffs. And within the studies, pediatric-friendly preparations were available, granule forms, etc. And then finally, the glecaprevir-pibrentasvir study in adolescents reported originally last year, actually published this year for the first of the pan-genotypic preparations, again with very high success rate. If we look at those small numbers that apparently did not reach their SVR12, these are the total of those patients from the studies that I've just shown you. You can see the first one there, an 8-year-old genotype 1 with cirrhosis, received all treatment, did clear the virus, and then the virus came back again subsequently. The others are discontinuation or loss to follow-up. So out of a total patient population in these studies of 418, the true efficacy seems to be extremely high. In addition to those studies, there are a few studies of genotype 4, I think from Egypt, showing high success rates. And then the sort of breaking news from late last year was the presentation at AASID of sofosbuvir-velpatasvir data in children from 6 to 17 years old. So the second of the pan-genotypic regimens, similarly showing very high success rates. That data is not yet fully published. So we have preparations that can treat children. We have high quality evidence to support that. And should we be doing it? Well, to help support that, Emma Greenaway, working at Sick Kids in Toronto, along with Murray Cran at UHN, has looked at cost effectiveness of treating children. And she looked at this by saying, how does it look if we treat children at 6 compared to waiting until 18 years of age? And she developed a model for this. The inputs to the model include the real Ontario healthcare costs. They include pediatric-specific fibrosis progression rates from a systematic review. For utilities, unfortunately, there's no work being done on utilities in children with chronic viral hepatitis, so she had to use the adult utility data. And two things really come out from that model. The first is that by treating early at 6 rather than 18, you can prevent children getting advanced liver disease. So if you treat 10,000 children, it's a lot of children, you'll prevent cirrhosis and HCC and liver-related deaths, according to what we can get from the literature to put into that model. And treatment is cost-effective on that basis at an ISA of $19,000 per quality-adjusted life year. So reasons to treat children with hepatitis C, as I say, it depends on your perspective, but I think we have data to show that we are likely to be able to prevent liver disease, that we can improve quality of life for the children and for their caregivers, and we believe that we're likely to be able to prevent transmission of hepatitis C before young children get through into their teenage years and start doing things that can transmit the virus to others. And the AASID guideline, therefore, recommends treatment for all children and adolescents once they're above 3 years of age. So the situation here in Canada is moving fast over the last year, and it's been difficult to keep up, and what's published doesn't necessarily match what actually happens. So Health Canada approval is now available for ledipasvir-sofosbuvir in pediatric patients above 12, for glecaprevir-pibrentasvir for kids above 12. Interestingly, there's no Health Canada indication for sofosbuvir or ribavirin for hepatitis C, although we have been able to use that combination successfully in 1 or 2 kids. In terms of cost coverage, it is complicated, as you might anticipate. We have had success for adolescents in the last year, and that is becoming somewhat easier to obtain the coverage required. Interestingly, at least in Ontario, where I practice, what's published on the relevant websites doesn't match what people are actually prepared to do. So our provincial coverage still states only for adults, but we have had success for adolescents. We're now really interested to move on to the ability to treat younger kids and see if we can get coverage for that as well. South of the border, the AASID recommendations for children turn out like this. So for treatment-naive or interferon-experienced non-cirrhotic children, these are the recommendations. If you're above 12 or above 45 kilos with any genotype, you can be treated with capavir/pibrentasvir for 8 weeks. If you're above 3 and genotypes 1, 4, 5, or 6, you can be treated with ledipasvir/sofosbuvir for 12 weeks. Other than that, there's a bunch of other recommendations that I won't dwell upon because they don't arise from pediatric evidence. They arise from the adult evidence and expert opinion saying it probably applies in children too. And then the one sort of remaining group are these younger children, 3 to 11 years old, with genotype 2 or 3. And here the decision is, do you use sofosbuvir and ribavirin, or do we just wait a little longer? Because we know that data for the pan-genotypic regimens in these young 3 to 11-year-old kids is already available, the data, and hopefully the approvals will follow. So perhaps for those, you can wait for the pan-genotypic regimen approvals to become available. So what are our additional challenges now? We have the drugs. We know some of our kids who have hepatitis C. I think we need to find the others, number one. And then for those that we do find, we have some additional challenges. So many of these kids have behavioral comorbidities arising from the challenging previous experiences they have had. Many of these kids come from difficult home life circumstances. Many are new arrivals to Canada. Many are refugees. And all of that adds to a complex mix for medical care. Several of them will have comorbid diseases that have to be taken into account in achieving treatment. And I mentioned the new immigrants and refugees. And we worry, of course, that we are missing children from marginalized populations and that there are many out there that we don't yet have diagnosed. So in summary, this is an important global health problem. It is small in number compared to the number of infected adults, but critically important to the affected children and their caregivers. The infection has significant impact on those kids and their families, and now we have effective treatment. We need to be concentrating on identifying the kids with infections and ensuring that they have access to these fantastic new medications. Thank you, everyone, for your attention.